اتفضل يا أحمد. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. شرفني اليوم إن يكون معنا دكتور إياد فاضل. ودكتور إياد الحقيقة اللي هيقدمه بما يليق به دكتور ياسر رضا. وأنا برحب بكل إخواتي دكاترة السوريين اللي هيشرفونا الأسبوع ده والأسبوع الجاي إن شاء الله. دكتور فواز، دكتور زبيدة، دكتور سمر، دكتور باسم، كل الإخوة من السيديان أسوشيشن اوف انستيولوجيست، والدكتور باسم ممثلا للأونكولوجي فيزيشن. أهلا وسهلا بالتجمع الرائع ده. وأنا بسيب الفلور للدكتور ياسر. اتفضل يا دكتور ياسر.
بسم الله والحمد لله والصلاة والسلام على رسول الله. Thank you, Dr. Safa, and thank you for the precious invitation to me today as a coordinator in this wonderful webinar. Not wonderful because of this collection, because wonderful because first time to join the Syrian Society of Anesthesiology, and our home become bigger and bigger every day. So the Egyptian Society of Anesthesia and Acute Care, it is not no more become an Egyptian society. It is an Arab society and also a global society because we have a physician from all over the group. Happy today to introduce my friend and my student and my colleague, now Dr. Eyad Fadel, consultant of anesthesia and pain management in Medical City, Al Qalamun University, Syria. After his finishing his training and specialization in anesthesia, he ran everywhere to get more and more from the science, like an what's called broad spectrum. So he joined the anesthesia from cardiothoracic, and I met him just to go after that to learn chronic pain after getting a diploma of cardiothoracic anesthesia from Shanghai. So Dr. Iyad, ni hao, xiao shangi hao. And after that, Dr. Iyad, I met him in Golf Business School as a teacher there and the trainer. I met Dr. Iyad in Agman University. Was a get come to train and to be certified, to privileged to work in bill management. He was one of the interesting people to me. He was fascinating because he read a lot and make a great effort to learn, and he don't shy. And he believes that doctor is alive when he study, and when he stop studying, he's dead. And also he was one of the first line people for the army fighting COVID, and he introduced three national projects which help in this crisis. Two of them, this crisis was about ultrasound. So he got a great experience in that and will share with us his knowledge today. We meet today to learn and to get some information from Dr. Iyad and to see his experience, a great experience during crisis, and the experience of Syrian colleague and physician, and to share this knowledge with each other. So now the stage for you, Dr. Iyad, and thank you for coming to Egyptian Society of Anesthesia.
Thank you, Dr. Yasser. Thank you, my mentor. Thank you. I highly appreciate it. I'm so grateful for this nice introduction to me. I'm happy and I'm so happy to introduce my experience, our experience from Syria to all over the world. The pandemic highlighted the importance of medical innovation, particularly in emergency and intensive care units. This presentation delved into the vital role of the lung ultrasound in patient care during this time. We will guide you through its transformative effects in emergency room and ICU. Our experience mirror of many medical professionals who traditionally relied on conventional diagnosis tools. The pandemic demands led us to embrace ultrasound not just as necessity, but as a patient, recognizing its potential value in the critical care. We will examine how ultrasound surpassed traditional imaging techniques, focusing on its real-time diagnostic superiority This technology provides essential in providing a clear, timely, and accurate patient assessment, altering the landscape of patient management. Lung ultrasound emerged as a crucial tool during the pandemic speed. Reliability and non-reliance on ionizing radiation made it a game changer. We will review case studies.
Dr. Eyad, please run the slide. It's only one slide. Yeah.
I'm talking just the introduction. And this discuss now, right now, importance of ultrasound in COVID-19 advanced life support. Here, to our God, my family and my wife, to all my teacher, including those silent teacher, to my patient and all my attendee. This Stanley Lamb and all my teacher, who I owe a debt of gratitude to them. COVID-19 early pandemic challenge. What was the first challenge we faced during pandemic? Shortage in PPE, cleaning supply, medical staff, isolation space, testing equipment, screening testing, issue travel, exposure history, fever and respiratory symptoms, testing time and accuracy, incomplete understanding of transmission, relation to symptoms, droplets and aerolization, gastric lavage also. Important epidemiology and prevention medicine made us should be ready and should be implanted this important field of epidemiology and prevention medicine in the upcoming pandemic. First of all, we started to learn to know about importance of mask wearing efficacy. Mask as the first reduce transmission from 70 when we one of us wear mask and the other no, and if the two, and it depends on the who is infected and who will carry, we should wear mask to reduce transmission from 70 to 1.5%, and this is this is very important to apply in the upcoming COVID-19 pandemic also. How many lives could be saved by mask wearing? We started to hear about silicone strain on our freedom. USA, 50% mask wearing rate was 40% transmission reduction. Higher rate in South Korea and New Zealand, sustained reduction in COVID-19 and economy are rebounding. And this is interesting. Should be aware about this. And the Institute of Health metric evaluation in Seattle also applied 90% of mask use in public good and also could save 130,000 lives. And this, how many lives could be saved by mask wearing and should be applied, and epidemiology and preventive first of all before starting in the diagnosis and starting to treat the patient of COVID. Impact of mask wearing during respiratory pathogen pandemic is hugely effective on public health and economic preparedness and resilience for emerging threat, WHO mode of transmission approach. Also, we have to talk about herd immunity. The level of vaccinating need to achieve immunity 83 to 94%. Herd immunity is very important term which we heard during the pandemic, COVID-19 pandemic. And we actually, as Syrian community research committee, we started and we involved in many publishing relating and regarding to herd immunity, and starting to scan after 3 or 4 months from during nearly about, I think in 2020 we started to scan the patient who admitted to our hospital who had infected in lower respiratory infection, and we search about we have we faced COVID-19 pandemic before while we were scanning about IgG and IgM after 3 or 4 months of COVID-19 spread worldwide. And this is actually the plan we started to apply in our not literally we applied, but actually we get a huge benefit from this plan. How can we how could take benefit and get a huge benefit from this? We reduced the admission cases to our hospital by consultation and telemedicine consultation. Actually, 90% of patients came back to isolated in their hospital in their home, and we started to started to treat themselves and take consultation on phone. And 20% of patients admitted to our hospital, and this decreased the huge number and crowded which admitted to our hospital. And also elective surgery, all of elective surgery has been postponed. Urgent surgery, we actually put it plan for urgent surgery. Actually, also all the orthopedic surgery and all the surgery can be done by regional anesthesia. We actually perform it by regional anesthesia, and also emergent surgery. We applied also regional anesthesia as priority of anesthesia plan. And also we have applied video laryngoscopy to decrease the amount of virus spread during the intubation of the anesthesiologist intubation. NISORA also we applied some advice from NISORA and some research also. Regional anesthesia in all medicine and all publishing and all guidelines should be a priority when we have many options for anesthesia, regional anesthesia or general anesthesia or spinal anesthesia. Regional and spinal is priority, especially for emergency surgery, like hip surgery, like knee surgery, like orthopedic surgery. If it is urgent, if it's emergent, it should be applied regional anesthesia for emergency surgery. This is plan we actually had applied in on all our hospitals. Our hospital in I just mentioned to I just referring to our hospital, which belong to medical service of Department of Medical Service. We actually we used ultrasound or X-ray. We didn't depend on CT scan. CT scan just for cases complicated cases should be scanned after using ultrasound. Rapid walking test also depend on it. And also we decreased the admission cases to our hospital from 100 patients may come to our hospital to 50% of all patients. And this make us we can do some we can accommodate with the shortage in medical services during the pandemic. Transition also to telemedicine in primary care. Also, it was very important, especially in UK. Most of the cases have been consulted on the phone. In UK, they increased in telehealth visit, shift from in-person to remote consultation. It was very important to all our hospitals to decrease the admission rate of our hospital and decrease the transmission to the medical staff and to all the people may come to our hospital also. And here we couldn't apply the telemedicine exactly, literally, but we could manage also the cases in emergency department. We have applied pre-triage in emergency department, pre-triage zone, depending on temperature and cough the patient and saturation. If the saturation more than 94%, the patient may scanning by ultrasound or X-ray, or we can do a rapid test if the saturation may raise after 300 meters walking. It should be admitted to our hospital. If the saturation 90 to 94%, it should be admitted to our hospital, and we can 90 to 94, it should be admitted to our hospital, and also we should see also if the patient suffering from COPD, we decrease the admitted patient to 4% of saturation. And if the saturation 96 for the patient suffering from COPD, may be admitted also to our hospital in isolation. But all of this, it may be make us to think about how to pre-triage. Why we didn't choose the CT scan or another imaging tool for scanning or for pre-triaging the patient. CT scan for COVID-19 diagnosis during pandemic. The finding on all the society, American society, and also society finding on chest X-ray imaging in COVID are not specific and overlap with other infection like influenza, like another flu. CT should not be used for screening for the first line test for diagnosis. CT scan can be restricted to patients who test positive for COVID-19 and who are suspected of having complication. If the patient have complication, we can do CT scan. Okay, and then what's established regarding lung ultrasound? Lung ultrasound highly accurate for detecting cardiogenic pulmonary edema. This is established. Inflammatory pulmonary edema, ERDS, also established. Pulmonary fibrosis, lung ultrasound is reliable in differentiating between pulmonary fibrosis and consolidation, including pneumonia and pleural effusion and pneumothorax. All this established regarding lung ultrasound. And it's very important also to remember that we use a lot of social media and exchange idea and practice pattern during the pandemic on Twitter and publishing on Facebook, on YouTube and webinar. We actually have seen a lot of doctors scanning themselves, like Chinese doctor. I have watched him during scanning himself while he is in isolation, in home isolation. Sonar transducer started in deep ocean, and when we were scanning for the fish, here's the story started. All TV version was TV static noise. Here we cannot distinguish between MSK muscle and all the tissue but with modern ultrasound we could distinguish the muscle, the layer, and also the lung. Like rib, we can distinguish rib, we can distinguish intercostal muscle, and we can distinguish pleural line, and also the lung. In the past, not for lung anatomical imaging of soul, fluid, cell organ, rapid attenuation in air in the past. At the present, prevalence of ultrasound importance in technology and image interpretation. Lung ultrasound is common. Point of care ultrasound. Right now, we can do ultrasound for all the organ of the body. Here we start. Lung window batwing sign. The batwing sign, here started the story of lung ultrasound. We can distinguish the rib, we can distinguish the lung, we can distinguish the pleura, we can distinguish the proof and the movement of the pleura, parietal pleura and visceral pleura moving on together, on each other. Lung ultrasound machine, no particular ultrasound machine. And here now you can see what was the machine we can using during the isolation hospital, which we started to isolate all the patient COVID-19 during the pandemic. It was Toshiba. I think it's the old version. In mode or time motion mode is important also for us to see the movement and to see the tissue of the lung. Suppression of artifact, not ideal for lung ultrasound. We will discuss later on this. Here we can see and scan the lung ultrasound. The lung. It's nearly about many area we can start to scan. 1, 2, 3, 4, and also L1, L2, L3, L4. There's a lot of, and also lawn mower. Also, we can like lawn mower. Also, we can scan all the body, all the lung, from anterior and posterior and intercostal. Also, anterior and posterior and in the middle. A blue protocol and lung zone. Here we can see R1, R2, R3, R4, L1, L2, and we can start to scan the. What's the importance of lung ultrasound? It's low cost. Repeated. We can repeat the ultrasound many times, and the accuracy of ultrasound and safe and fast decision making. It's very important, this point. Here we can see and distinguish the rib and the pleura line, and we can distinguish the muscle, also pectoralis muscle, skin, and soft tissue. And here we can also pathogenic lung point. We can see it on the CT scan and X-ray, but can we do it also by ultrasound? Yes, we can do it. Normal lung ultrasound, to and fro movement, sliding visceral pleura, static parietal pleura. This is the movement of the normal lung. And we can see also comet tail rocket artifact. This artifact we will discuss thoroughly about it. Start at pleura. It start at pleura. Here we start at pleura, and it's very important also. And end edge of the screen. B lines rule out pneumothorax. Is that if we can distinguish and find B lines starting from the pleura to the edge of the screen, we can rule out pneumothorax. Negative predictive value is very important for ultrasound. We will continue. Normal lung ultrasound rule out pneumothorax. Lung sliding, lung pulse, which we can find it on the left side of the chest. Lung pulse, in mode seashore sign, we can see it later on. Pathology diagnosis pneumothorax lung point. I will show you the lung point exactly. How can we find it? In mode barcode or stratosphere sign, we can also find it, and also a 100% diagnostic sign of pneumothorax. Normal lung, in mode C, sure sign. We can see ocean waves, breaking on sandy beach. Ocean waves breaking on sandy beach. This is a very important sign for normal in mode lung. And also normal lung, we can see shimmery, shiny, correspond with the respiration, which is normal. Visualizing of pro movement of the visceral and the parietal lung, we exclude pneumothorax. If we can see lung sliding, we will exclude rule out pneumothorax. Pneumothorax aspirate the pleural layer and movement disappear. Here we can see lung point and M mode. On M mode, we can see here the point where the lung point. It is exactly. If we can see here, part of pleural line movement, and here it's fixed. We can scan in M mode to see the movement in every second for the lung tissue. Here we can see the barcode. This barcode is 100% diagnostic sign of lung pneumothorax. Here, the big pneumothorax, we can check it here exactly as this place, and this from blackjocks.com. I got it. If the pneumothorax resolved, we can check, and this also depends on the position of the patient. Here we can check for pneumothorax and lung point. This is the diagnostic sign of lung point. This lung point, and here also lung point. One of the one part is movement, and the other part is fixed. No. And this is the flow chart for lung sliding. If we can find lung sliding, it's possible pneumothorax. If lung sliding, yes, no pneumothorax. And this negative predictive value is very important for us to rule out any suspicious of pneumothorax for patient coming to our emergency department with dyspnea may in diagnostic differential diagnosis pneumothorax. Possible pneumothorax, we can search for P lines. If P lines find, we can rule out pneumothorax. If pneumothorax, if P lines no, here we can search for lung pulse. Lung pulse, no. Seashore sign, search, no. Lung point, it's fine. Pneumothorax is 100% diagnostic test. Here started the story. Ultrasound artifact. In the past, we were talking about artifact as a problem in the machine, but we discovered something in the not recently, in the past also, that this artifact it's very important for us. It's treasure. It's historic treasure for us. And here started its moment of sudden insight. We started to talk about artifact is very important for diagnosis. Here we started in Mysora. We can see the photo in Mysora. E lines, it's normal lung. B lines, more than 3 lines, it's not normal, it's abnormal. And here the consolidation, our C line or consolidation. We will continue. Why it's important, the ultrasound. Routinely, as anesthesiologist, we can use ultrasound for nerve block and central venous catheterization. We cannot always view needle tip, and for this reason, may we puncture the pleura. Rule out pneumothorax and documentation is very important. After CV line insertion, we can scanning 2 sides of lung and rule out pneumothorax in documentation. If we cannot waiting for X-ray, and also we can depend totally on ultrasound right now. Checklist for using ultrasound, we can insert CV line by ultrasound to be sure also in that the guide wire also insert and the needle insert, and also we can rule out the pneumothorax after being sure of lung sliding present during the scanning. Meta-analysis by Chang et al. 2011. I'm talking about 2011. It's the first ultrasound machine was pulled to study on pneumothorax lung ultrasound versus X-ray. Gold standard CT scan, but we are talking about 52 X-ray sensitivity and specificity 99. But we are talking about lung ultrasound 99 and 100 specificity. And this is, I think it's very important, especially we are talking about 2011. Perioperative decision, lung ultrasound 250 ICU admission with dyspnea, pulmonary embolism, chronic heart failure sensitivity 97 and specificity 95%. Asthma also COPD sensitive 89 and specificity 97%. Pulmonary embolism with DVT, and also we should scan for DVT. If the DVT found sensitivity 81% and specificity 99%. Pneumonia sensitivity 89%, specificity 94%. And here we are talking about 2008 Blue Protocol. Lung ultrasound prior outbreak sensitivity was 94%, specificity 84.8%. High interior observer. Also agreement distinguishing viral from bacterial pneumonia. And this is what we are talking later also. CT scan for COVID-19 diagnosis, ACR recommendation. Finding on X, all the society not recommend to using CT scan for as the first line test for diagnosis, and also not specific and overlap with other infection. And CT scan restricted to patient who test positive and also suspected for having complication. We talked about this before. 5 reasons to choose ultrasound over CT scan during COVID. Emergency Medicine Expert Panel 2020. And this is what we have applied during pandemic in our country and in medical service of Department of Medical Service and all the hospital belong to it. Rule out other pulmonary disease. We can rule out other pulmonary disease by ultrasound. We can help with venous access. We can pinpoint. We can help with venous access, especially all the patients with COVID-19 coming to our department. We cannot sit. We cannot sit on the bed because the saturation is very low. For this, we can insert the central line while the patient in half seated, and pinpoint any new heart issue or ones that COVID-19 has worse with cardiac ultrasound. Point of care ultrasound can help control viral exposure. Also, it's very important when you compare with CT scan. Where the patient coming to CT scan, it can spread all the virus all the way to the radiology department. You as the ultrasound, regardless of result, can be clinically beneficial. Why? Normal finding, avoid unnecessary additional imaging. Don't need. If normal finding, the patient don't need CT scan, don't need X-ray. Any abnormalities, characteristic of COVID-19 isolation, direct the patient appropriate hospital. Observations that ultrasound may precede the clinical symptoms suggested. The finding, the finding on ultrasound precedes the clinical symptoms. That is it's overcome the CT scan. CT scan, the symptom, the finding can be just distinguished after 3 days of CT of the symptoms. We can find some radiologist images on some finding on the CT scan, and then a position statement on the use of ultrasound guidance CV, central venous catheter and peripheral venous access. Central venous access technique. It's recommended for to use ultrasound, standardized checklist combined with real-time and aspect technique and maximal sterile barrier precaution. Internal jugular vein real time to reduce mechanical infection. Number of needle paths increase success rate. Subclavian vein mechanical needle pass success rate. Landmark technique. Femoral vein reduce artery puncture time. All this it should be this maybe this slide it's before. And all the recommendation on the use ultrasound guidance for central and peripheral vascular accident in adult, position statement of the Society of Hospital, all of the recommendation talking about using ultrasound for central line, for jugular vein, for subclavian vein, for to check also to rule out any pneumothorax after insertion of CV line. And this is what I was talking about. Any procedure, and also it's also the recommendation also about insertion of radial artery, and this is for radiologists. It's recommended also. Pre-procedure familiar should be the doctor familiar with procedure using ultrasound, high frequency, sterile sheaths or gel, two-dimensional, evaluate variation, thrombosis inside, evaluate the blood vessel size and depth. It's very important also. Real time, in general technique, real time avoid static alone. So all of the technique should be in real time. Either a transverse short axis or longitudinal, we can visualize the needle tip also and guide wire. This is what I'm talking. The position statement of all hospitals recommend using ultrasound and rule out the pneumothorax after insertion CV line, and also recommend for using artery catheter using ultrasound also. Ultrasound, DS X-ray in central venous catheterization, superior detection of pneumothorax compared to radiology, immediate post-procedure exclusion also, reduce CV line confirmation time. When you are comparing 6 minutes, DS 64 minutes to 143 minutes, this is enough for patient to be passed away, while we are going to diagnose and searching for any radiology if it's available in hospital or not. Advanced training, resident minimal training recommended for RAS technique. RAS technique is to check if the catheter it's in the place or not. RAS technique, this is the complicated, we are afraid to if we can do it or not. And also short access we can do in short access check and long access we can do also. And this blue protocol, lung zone, we can do in zone 1, zone 2, zone 3, zone 3. B-lines fluid in alveoli also we are sorry. Yes, I want to. Yes. And here, normal lung mode seashore sign present with normal sliding. This we can find also the normal mode view, seashore bright, plural line, sandy beach, breaking on ocean waves, breaking on sandy beach. And also we can distinguish the effusion, the squad sign. We can distinguish a little amount of pleural effusion by this sign also, squad sign. Schematic overview of like blue protocol, we can see C profile, it's 100% of pneumonia. We can also B profile, no sliding pneumonia also. A profile plus sliding plus thrombosis, embolism, maybe, not maybe, it's 100. I'm talking about high percent diagnostic schematic diagram. A profile, lung point, no sliding, pneumothorax 100%. And here also blue protocol, and we can find E lines, P lines, ABC line, and B lines. And like I told before, C profile pneumonia. And especially we have to overlapping also a clinical presentation of the patient coming to our emergency department and lab also, like we had done in our hospital during COVID-19 pandemic. We extended blue protocol also. If we have lung sliding, present B profile. Also, we can check for left ventricular contractility impaired, left ventricular contractility preserved. We can distinguish between pneumonia and pulmonary edema if we have B line and lung sliding is present. And it's also very important. Here we can see COVID-19 pneumonia phenotype identification. How many point of care it can be done right now? Point of care we can do for cardiac, for lung, for also for fluid states assessment, deep venous thrombosis, ECG, transcranial. Also, we can do it for stroke diagnosis, tele ultrasound, and it's the most important telemedicine. While the patient in his home, maybe the nurses deployed and employed to be as a part of medical staff and the first line staff who can make the patient stay in home or to make the patient admitted to the hospital. This diagnostic metric for ultrasound in NISORA, pleural fusion 94% specificity, 97 consolidation, including many diseases, 90%, 98%. For this reason, it's very important to gather all the information about the patient, clinical lab, imaging like ultrasound, and all the clinical history for the patient coming to our hospital. It should be overlapping and covering all the information to make the right diagnosis. Lab pneumothorax 100%, specificity 90-60. Occult pneumothorax is very important, 79%, 100% also. Ultrasound can be distinguished. And here we can also see the viral and consolidation pneumonia, how can be appear on the ultrasound, the E-lines, here E-lines, small subpleural consolidation, large lung consolidation, air bronchi, and lung consolidation. All of this pleural effusion, pneumothorax stratosphere, a sign on M mode, and acute cardiogenic interstitial syndrome include acute cardiogenic pulmonary edema, chronic heart failure, acute lung injury, pulmonary fibrosis. All of these we can distinguish, depends on B lines and B lines distribution and other like a pleural fusion. All of them, it should be gathered if the patient coming to our department in acute phase or a chronic phase, and it's important also to scan and point of care of cardiac to check the EF, ejection fraction of the heart also. This starting from the black lung, black and white and gray. This is the stage of the acute ERBS and the stage of COVID-19 also, B lines. A lines, B lines, and C line also. This during COVID-19 it appears this diagram. E lines normal, B lines partially aerated, C line consolidation, combined ABC line also we can see during the ERDS. Here we can see E profile. What it refers? E profile that plus sliding, maybe COPD, asthma, pulmonary embolism, posterior pneumonia, and we rule out pulmonary edema. Nearly rule out. P profile plus sliding, pulmonary edema, COPD rule out, pulmonary embolism rule out, pneumothorax rule out, potential. This plus its potential diagnosis negative diagnosis rule out. AB profile plus sliding pneumonia. It's most diagnostic most diagnosis. Rule out pulmonary edema, COPD, rule out, and asthma rule out. And here, lung ultrasound vs CT scan diagnosis COVID-19. Lung ultrasound hold high diagnostic agreement with CT. It's comparative lung ultrasound and computer and CT scan diagnosis patient with systematic review and meta-analysis. It's the same, but the cost is so different between the lung ultrasound and CT scan. Lung ultrasound holds high diagnostic agreement with CT, point of care portable tool. It's the most important, simple, low cost, and accessible and safer. Experience with CT scan and lung ultrasound finding in COVID-19 clinical presentation and symptoms duration, continuum, unilateral, multifocal, glass ground obesities, bilateral, diffuse GGO, mild GGO consolidation. Lung ultrasound findings seem to correlate with CT scan, and this is the most important. WHO recommend using ultrasound during COVID-19, and this Felici and Tolga ergonance also. And also we can treat depend on the imaging of ultrasound and imaging of CT scan, and this during the guideline of COVID-19. Adult advanced life support algorithm. What's the importance of ultrasound in advanced life support right now? 4H, 4D. We can search patient coming to our department with dyspnea and going to it's unstable patient. It's patient coming to our department with dyspnea and saturation very low. We can search for 4H and 4D, and we can rule out hypoxia. We can rule out hypovolemia by ultrasound. We can rule out tension pneumothorax. We can rule out cardiac tamponade. We can rule out thromboembolism. And here will give us a time for treatment and for saving life of this patient. And this follow protocol is very important also, and totally depends on the plan which we lined and we worked on during the COVID-19 pandemic. A profile, if it's A profile or B profile. If the patient, simple emergency cardiac sonography, it's supposed to be point of care cardiac. Lung ultrasound, blue protocol, A profile or B profile. If the patient suffering has B profile during ultrasound, cardiogenic shock. A profile, we should give the patient flow therapy. No clinical improvement. A profile is generated usually hypovolemic shock. If the patient with A profile with a clinical improvement after giving fluid therapy. And this COVID-19 patient evaluation flow chart also, we patient with symptoms and laboratory during pandemic history, smoker, COPD, IHT, and heart HCM, also lung ultrasound, viral vs bacterial, also we can distinguish. Here's a story, lung ultrasound, patient coming to our department with scorpion bite, coming to our department. Can we discharge this patient or transfer the patient to another hospital from the first aid hospital to the advanced hospital? This also depend, we were depending on the first scanning lung ultrasound. If the patient has P lines, if the patient has a low EF, starting to suffering from heart low EF, we should start heart support for the patient, and then we can transfer the patient after admitted to ICU, temporarily admitted, and start support and intubation if he needed. We can distinguish if the patient started to suffer from subacute edema by ultrasound, and this is very important used for ultrasound. Point of care role of ultrasound in COVID-19 pandemic, what lies beyond the horizon. This for Felici and Tolga. It's very important also. We can do a role, point of care for lung, for heart, for DVT, also for pulmonary embolism, for EcoFast for abdomen, and also for eye, and this is very important. And also talking about the time which we can use it for to save the patient. If we use ultrasound to central line, to insert the central line to rule out the pneumothorax. And this accuracy of lung ultrasound in the hands of non-imaging specialist. If we are talking about, can we do it by non-specialist? If we can do it by anesthesiologist, it can do it for nurses. Yes, we can do it for just for basic. If we applied or deployed all the nurses, all the medical staff to do some basic lung ultrasound, to deploy all the medical staff during the upcoming COVID-19 pandemic in the future, or any pandemic like COVID, or like pneumonia, any viral pneumonia, we can also we can take the we can deploy all the medical staff after basic training on ultrasound, music ultrasound, starting from telemedicine in the home, to scan the patient in the home, to scan the patient pre-triage in emergency department, to isolate the patient before enters the isolated hospital, and then we can deploy all this. For this reason, it's supposed to. It should be national drive for to train all the medical staff in the future. This first case, suspicious, came to our hospital in the past. This patient with the simple ultrasound. I think this patient coming to our with suspicious, the first suspicious COVID-19, saturation 84%. He has also suffering from cellulitis and dyspnea. Admitted to in ICU. Admitted in ICU. This patient had admitted to ICU and intubated after after he suffering from critical and going to be after the saturation decreased very low after giving low oxygen. The patient intubated, and also we were suffering from pleural effusion. This patient also was suffering from pleural effusion. I think this pleural effusion, and this sign also was suffering also from jellyfish sign. Jellyfish sign, and we evaluated the amount of the pleural effusion for this patient, and we diagnosed with pneumonia, but the lab and PCR was negative. And we discharged the patient while he is intubated to another hospital, which not because that hospital was just just equipped for COVID-19 patient. It's discharged and transferred to another hospital, which treated and extubated after nearly about 15 days of intubation on ventilation. But the story from this patient, it was after 1 year coming to another hospital, the same patient. In this CT scan, the PCR for that patient was negative, but the ultrasound was compatible with COVID-19. But this CT scan, it looks like COVID-19. But the pleural effusion with ultrasound, it refers, maybe it makes the diagnosis going to the bacterial pneumonia. And this was the finding on this patient. Maybe it was The patient coming to our hospital with amputation and was preparing and was consultation for anesthesia, and we did all the surgery by regional anesthesia for amputation on land on the explosion, after explosion, was suffering from explosion on the foot. The patient, the problem in this patient, maybe the CT scan after 1 year, and the saturation was so low. And this maybe PCR is negative, and ultrasound was positive. Ultrasound was positive. I necessitated and asked to do PCR second time, maybe COVID-19 combined with bacterial pneumonia, and this is what I think in Mysora, if the patient admitted to our hospital was positive ultrasound compatible with COVID-19, maybe and the PCR was negative, it necessitate to repeat again PCR, and this is what I talked during this patient. Take home message. This is in brief. E-lines, P-lines, B-lines, and consolidation hospitalization. It's for this patient, maybe we can admit the patient for the hospital. Here, the patient also, it can be admitted to the hospital. Here, it's charged to the, this depends on ultrasound. But why ultrasound is so important? Telemedicine and home consultation is very important. We can deploy all medical staff effectively in any pandemic may face in the future. Basic training courses for all potential medical staff is very important for us. Pre-triage in emergency department is very important. Rule out other suspicious medical conditions is very important. We are talking about negative predictive value for ultrasound. Central line insertion safely, we can do it. Checklist, also documentation after central vein catheterization, we can use it. Also, as bedside tool in ICU, also decrease infection transmission when you compare with CT scan. Classification of disease stage and change therapy accordingly. Also, it's important for using ultrasound. COVID-19 patient have finding on ultrasound which can be used to rule out COVID-19 alongside all other clinical and radiologist parameter. There is national drive in UK, in EU, and American also determine the role ultrasound and point of care ultrasound in diagnostic pathway of COVID-19. Lung ultrasound and point of care needs wider uptake by healthcare practitioner during pandemic provides a unique opportunity, and during pandemic provide unique opportunity to do it. Epidemiology and preventive medicine should be thoroughly implemented in any expected pandemic in the future. And this is stethoscope of the future, it's ultrasound. And this is not just a stethoscope, it's multi-organ point of care. It's heart pain, we can do heart pain access also by ultrasound. We can do central venous catheterization, rapid and targeted management decision, and first line team safety is our priority also. We can use it by ultrasound. And a reference, this is a reference, thank you.
Thank you, Eyad.
Thank you so much. I'm sorry, maybe the traveling and
Yeah, no. It was great presentation, really. Very simple, but very comprehensive and full of many valuable data, of course. Great, Eyad, great lecture, really.
Thank you so much. Maybe 2 slides, it's deleted. I don't know why. The first 2 slides. The first 2 slides, it was deleted. I don't know why.
What is
Thank
deleted?
For your attending, Dr. Basim. Dr. Basim, he is my mentor. And
yes, I know. This Dr. Basim. but the phone appear for us is Lenovo, not Dr. Basim name. So he cannot change his name, but I know him from the photo.
Yeah.
Dr. Basim Dayoub, he is the leader of a scientific committee in my country, and he
Welcome,
was
Dr. Basim. Welcome, Dr. Basim.
all the research.
Good evening. Good evening.
Good evening, Dr. Basim. Good evening. Welcome.
It's my pleasure to be with you in this event this evening with the lecture of my colleague, Dr. Fadel, to speak about our experience in facing COVID-19 pandemic in our country. So it's my pleasure to be with you amongst you as a professional, health professional in anesthesiology, in pain relief. So my conversation will be in a little point, because I am oncologist, not in this specialty of you.
Yes.
So I will talk just, I will mention a conclusion of systematic review addressed ultrasound findings of lung ultrasonography and COVID-19 is systemic review led by Jim Jill Rodriguez and published in Europe Journal of Radiology in March 2022. The conclusion said the most frequent ultrasound findings of COVID-19 are the presence of B lines and pleural abnormalities. Lung ultrasound score is associated with ICU admission, need for mechanical ventilation, and death. The inclusion of pleural effusion in the lung ultrasound score and the standardization of the imaging protocol in COVID-19 lung ultrasound remains to be defined. I mentioned this systematic review to say in COVID pandemic in our country, we faced many challenges. The one is the big number of patients suspected of COVID and referred to our hospital. And the second challenge is we need to have a rapid act to facing this big number of patients. And the third challenge is to meet requirements of enabling this big number of patients to have the suitable health care. And the fourth challenge is to meet the requirements of the healthcare for COVID pandemic. And there will be another challenge. I will listen it in the final of my speaking. So why ultrasound? Ultrasound is an easy test, manageable test. We can benefit of his effect in our guiding the care of our patient. Very simple. We can take it outside the building of the patient, in front of the patient, in isolating space. This is one. The second, it has a good role in diagnosis of COVID-19, and also it can monitoring the development of the disease. We can explore the changes in the lungs, which correlates with COVID-19 infection. Beside the other indication, which was mentioned by my colleague Fadel, it is a safe test, and not expensive. We know in a facing a big number of patients, we have to use a simple machine, a simple test to guide our health care. Also, ultrasound make or enable us to get a direct image, a vital image, so we can monitor the development of symptoms in the real time and making the right decision for the treatment as rapid as we need. My colleague mentioned very big amount of information, very beneficial information, but I will add, we need the lung score, which from 0 to 3, normal, moderate, severe, and complete loss. So, as a health professional in building up a pandemic strategy for facing COVID infection, in this context, I can say ultrasound is a beneficial instrument in a triage of patients suspected to have COVID-19 for treating them as rapid as we can. Thank you for letting me to give this short insight in your lecture.
Thank you, Dr. Basim. Thank you so much.
Thank you, Dr. Basim. Thank you. Thank you for valuable contribution from your side. Thank you.
Dr. Basil, I have a comment. You are making, mashallah, very good comment on Eyad Fadel, but I can extend my words. You see that ultrasound change our life, not just for COVID, for regional anesthesia, for pain medicine. And now the technology become very easy, so you can hold a probe in your pocket, working in any machine, iPhone or any smartphone. And this changed the life, and let someone to said it will change the stethoscope you're putting in your neck and can give you more data. And I'm scared to wake up one day for a surgeon to tell me that I make a cesarean by ultrasound. Um,
Yes,
and
yes, of course, you are right. You are right. You are right.
Thank you so much, Dr. Eyad. Yeah, thank you so
and
much.
I have two questions for my colleague, if you permit for me, Dr. Safa, Dr. Iyad. First thing, you speak about the mask. When the COVID pandemic started, they said that N90, the only mask can help to protect you against infection, and the other mask, daily used mask like an OR mask, is doing nothing. So I want to ask about this. This papers, what he said about the type of mask.
I think I'm not talking about what type of mask we have to wear.
Yeah.
As we have seen before, we applied the mask N95 or something like that. Maybe it's better for medical stuff, but for protection and for masking and decrease the infection rate during the population. It's supposed to wear mask you and suspicious patients for this to decrease the transmission rate, and to like New Zealand, like South Korea, it was the most how can I say discipline in wearing the mask, and in this two country was a rebounding economic was rebounding fastly because the wearing the mask, it was all of them disciplined to wearing the mask.
Yeah.
And there's a system, and there's a punishment for anybody not wearing the mask.
Yeah. My second question for you about you speak about the vaccination and immunity, but we know from the literature now and from what we see from the vaccine the vaccine was like a lie because it's starting the research in 2016, and this came from Pfizer itself. And for me, I take the vaccine because I want to travel, because without vaccination, you can't travel. So I take 2 shots. The third shots, they cause me a disease and about to die. I can't take my breath. I stay for many days. And all the people seeing that, even my wife. And what I see in my clinic about, I see myocarditis, heart failure, patient died. I see a patient, 2 patients with fleeting pain. They've been getting edema, fleeting, and pain. And I see a pilot, the fighter, and get bilateral amputation because he get an DVT during thrombose during a viral infection. And I see myopathy, I see paralysis, an 18 years old lady. I see too the necrosis of bilateral head of the femur. I see all this patient in my clinic. So I think the vaccine, not as you said, an immunity vaccine, it was a lie because we got a problem more than this. And even some of my colleagues don't take the vaccine. And for me, for my experience, I take 2 times COVID. The first one, I was on Thursday. I went to the work and I came a little sick, feverish. So I take paracetamol, non-steroidal, sorry, and antihistaminic. I just went second day to make a test. I found myself positive, so I get another dose of paracetamol. And in Saturday or Sunday, I become totally okay. I don't have any problem. And one day I get a severe infection. I think, and I can't take my breath. I think saturation going down. I take all the medication and went 3 times to make a test. I found negative for COVID. So I think many types of influenza more than was powerful than COVID now. And the COVID not finished. We have everyday COVID in OR, but we don't take any restriction like before. So you know that I think we don't know a lot about COVID. Yeah, and you remember the arsenal of research, like a plethora, many research. Someone said this medication is good, the other research is bad. So it was a conflict, and I don't believe what said during that time. And just at the within few months is finished, and something came again. I think the economy and lies plays in this issue. But I'm telling you, I'm thanks for COVID because we learn a lot from COVID. One thing I learned about this ultrasound use in everywhere, because it was a very difficult to bring a patient, even since our job from ICU to go for a CT in our hospital, or we can district part, far away area, like was in a small hospital, like an hospital punishing the people there, and was far away from all investigation. You take the patient running, going, and this is our job all the time. So I found ultrasound make a renovation, not just for COVID, but thanks for COVID, because we learned a lot from COVID. And I think we are now more better than before. And thank you, Iyad, for raising this issue. Even after COVID, but after COVID, COVID not finished. We have every day COVID. And you know that a few days ago, six of anesthesia member have a COVID. But now we don't take it like before. He just take and treat 5 days, and there is okay, it's okay, and no restriction like before. And thank you, Iyad, for the presentation. I
And
finished my.
please let me to say comment also, Dr. Yasser, that of course, thanks to COVID, because initiating telemedicine, and now we are in this online meeting because of COVID.
Yes, this is
Telemedicine
one of the
encouraged.
good advantage, because even we don't stop after COVID
Yeah,
stop, you know.
yeah,
Yes, for
yeah,
education.
yes. Thank you.
I
And
just,
I think there is a paper in that, it's many paper
Yeah.
about use of
Dr.
media during COVID time, and will benefit from that. So nothing is have a black side and white side. And
Yes.
thanks for that.
I just want to mention about herd immunity. Herd immunity can be done by vaccine and by leaving the population to get infected by the virus and getting herd immunity, like German, like some some cities in Germany have been done many case study about the scanning of all the IgM and IgG about it was the COVID-19 passing and maybe also many country like Finland and another country left the people and the population to get infected and to get herd immunity naturally. This is we can do it also.
Strong will live. But I tell you, yeah, he had a very interesting thing during my COVID, because I'm diabetic, and they tell us diabetic people not allowed to work. But when the first line died from working 12 hours every day, they tell us the second line can work. And I believe me, I see many patients with cancer and taking cancer management and take a corticosteroid. Very sick people, very sick, and we have a low immunity. People for bone marrow transplantation, and they got infected and passed very easy, very fast. And I found some people which is very healthy and very strong and about to die. So I think there is some other factor, not just the immunity, because you see the immunity is very good, but the patient not survive. And some patients we know the immunity is very bad but survive. And even very old people which have many comorbidity and they pass. And because of that, they let us to work. Because I'm diabetic hypertension, they let us to work because you know some data that it's not just related for the comorbidity, it might be related for something else. And I
Yes,
think you agree with me because you see many cases about that.
yes, 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 Dr. Yes, it's true.
Any question from the chat, Dr. Asma?
I don't see.
Can I add something, please?
Yeah,
Sure.
I mentioned little minute ago, there is a fifth challenge of the challenges I mentioned just a moment ago, is the post-COVID syndrome, which is a big challenge for all the universal, medical universal, because we had now many medical presentation which is a little changed of what we had known, what we had taught in medical faculty. So we must focus in our patient who admitted to hospital, looking for any manifestation, irregular manifestation. So, as a head of scientific research center, I was one of the expertise who studied the COVID vaccination for permission of its entrance to our country. But I don't take the vaccination. As a doctor, I don't take the vaccination. It is my convinced that I don't want this vaccination. The second one is I insist for all the doctors in our hospital to register in the patient record if the patient had a previous COVID-19 infection, or if he had received the vaccination, because I think in the future we will have something to talk about this infection and this vaccination in the context of post-COVID syndrome.
Yes, great, Dr.
We're collecting the data, you know.
Allow
Yes,
me to have a comment, just to remember the incidence of intrauterine fetal death more common post-COVID, the incidence of sudden death due to myocardial infarction and myocardial fibrosis post-COVID is common. Also, some people when getting the vaccine, they have a sudden arrest and sudden loss of consciousness, and they are died by the vaccine, not by the disease. Also, COVID-19, I have a very bad experience with it. Many of our colleagues and friends died because of this pandemic. They have the same features nearly. So I suppose that the phenotype and of course, consequently, the genotype influence the severity and the comorbidity associated with the COVID-19. Even they
Yeah,
are, they have, they had no, they passed away. They had no any comorbidities before the infection by COVID-19.
yeah. And I think Dr. Safa also just says that collecting data every day we discover something because not
Yes,
the both COVID syndrome appearing immediately because there is an early manifestation and sometimes we don't know what happened. We don't know. It may be coming in the next generation. As a
yes,
joke of one of my colleague working in New York in the crisis of this one, he tell me I don't know, but I take a vaccine one shot and I don't continue because after the first shot he was joking at that. He told me I don't like banana before, I like banana now. And he wanted just to walk beside a tree. I want to jump over the tree. So this is one of the manifestation for was joking. But now we discover everything. You know, these people take a vaccine from 2 years, but the manifestations appear now. I see all these cases in 6 months. And
yes.
this is being clinic. What about other specialty? I think my colleague in other specialty saw more and more from this case, and I think Iyad will say. And sometimes it's challenge for pain management. For me, I make a block, the patient not relief, and the pain has started to appear in another, starting for one limb, and it come after 2 weeks, tell me just a mild improvement, and the other limb becomes swollen and severe pain, and the patient, you know, and you tell me the pain is fleeting in my body. This all this after vaccine. He knows this is after vaccine because he was a health worker. So I think we're just waiting for more data, maybe another generation to see what happened for these people. I don't know.
But I mean that if we have work up scheme to follow this patient every, for example, 3 to 6 months, for example, CT, for example, ultrasound, for example, some lab investigation unique to this group or special entity group of patient to see the manifestation is getting worse or getting improved with time. But
You
who
know,
will
you
thinking
mean,
about this scheme?
what do you mean? You mean to see the people take a vaccine to make us follow up? But I speak about that the people came with this manifestation.
Both
Yeah.
the vaccinated and the infected by COVID, by certain lab
It is a good
investigation.
matter for the research, I think, and I think
Yes,
my colleague who can make an international project, not just a national project, and to see from everywhere to see what happened and
of
to
course.
count this
That's what I
manifestation
mean.
because I see a lot,
Both.
not just one specialty, not our specialty. I think other specialty
Yeah, of
can share
course,
with them.
of course, multidisciplinary team, and all are thinking together to collect the data from here and there, and they
Yeah.
do a scheme for lab investigation or in any type of investigation, the history, and follow up the cases for at least 2 years. For
Yeah.
example, for 2027, to see what happened from the virus or the vaccine.
What's your opinion, Dr. Rayad?
For post-COVID, I'm not interested.
Yeah.
Before COVID and for diagnosis,
COVID is enough.
I'm interested. I'm
COVID
very
is enough for you.
uh,
The battle finished.
told the brief about how we
Alhamdulillah.
in the future for any upcoming COVID or any upcoming pandemic we can face, especially if it is pneumonia or it's
No, they be repair soon for anything. Yeah, I think I'm just with an I'm thinking in serious way and bad way because I think everything is was called manufactured
Yes.
and they started by SARS. Was called every time you bring something and make a media and a very big thing and finish.
Yes.
But the COVID was the worst because I think it's manufactured, prepared and many company working for the vaccine even before to start. And Pfizer said they would started vaccine 2016 away from the COVID. And I think this is a financial issue because most of people working in pharmaceutical industry is heartless and they use an Africa and some countries just for research like an animal. We are an animal for him. We don't need no, so I think we learn from COVID not to take everything what is telling us to do. You must
Yeah.
we must have some research and something to do. This is what I believe because you know that we live in 2 years in a very bad situation, and all the time I think and not survive. Every day I hear about some of beloved one is lost and don't have anything. Everyone was waiting for his time to come, and it was a very bad thing. It was an moral, it was an psychological, it was an everything. And
Yes.
at the end, the picture starts, the fog start to go away, and the picture start to be clear for us. And most of our doctors don't take a vaccine, even when you take a one shot, they don't continue. Before was running and fighting to take a vaccine. And I think Qatar was one of the first country to bring a very big amount of vaccine for free for the people here from Pfizer just to try to protect. And I think it pay a lot of money because people don't understand except the money, you know. And this is a company. And you know that for your knowledge that Pfizer win trillion, I think $5 trillion is very big amount of money. And the American government take a very big amount of money, about 50% of this money.
Yeah.
So
So they manufacture virus which attack our respiratory system. The second time
yes,
may attack another system. We don't know.
I don't know. Yes, every time.
Yeah.
Yeah, so
we we
uh,
we mustn't ignore that in the releasing of this vaccination we getting very we didn't strict with the FDA organization
yes,
about the period of any vaccination, any drug to be FDA approved.
yes,
So this is a critical point that in the context of human needings, we release the vaccination before completing the entire process to validating this vaccination. This is a critical point, I think.
yes,
Yes. Yes.
yes. And
Yes.
also before the study to see what is the percentage to prevent the disease or to combat the disease. Even I tell you, I take doses, and I get one time between the second and third dose. The second time I get it after the third dose by about 3 months, and you know I get. But it was very easy, but very easy. Less than the third dose of vaccine, less than the regular influenza. You know.
Yeah. Yes.
And you ask Allah not to return this time again because we are just, you know, if, even I think socially people are still suffering, you know. We do something from COVID and up till now we don't just cured from to do the social activity to visit each other. People still have an, you know, psychic trauma, you know, from this COVID.
Yes. Yes. And always
Um,
you behave to be aware, even if your friend have a cough or any symptoms of respiratory system,
yes,
you
yes,
be aware and pushes to be close to him.
yeah.
This mania.
And still up till now, if you're in a flight and coughing, all people looking at you. It's like a crime. And there is a comic in America said, bring up people said, he when I was just I was make a fraud or just make a flatus, I was covered by cough. When I make, but now when I make, I want to cough, I cover by flatus because this is more acceptable than coughing now. You know that's like, and
Yes,
I ask Allah everything to return back to normal, inshallah.
inshallah.
So it's okay to press 5 minutes.
Yeah. Um, inshallah, the next Saturday we will have also our great Syrian committee with us, but the presenter will be Dr. Fawaz. Will have presentation about. So I will show it you for you. Dr. Fawaz will speak about the natural or artificial colloid. And of course, all of us will waiting for him. Today he has some familial issue I can't mention because I don't ask him to mention or not. So I ask Allah subhanahu wa ta'ala to bless him and his family. He will come next Saturday. It will be February 3rd. And will speak with us about the natural and artificial colloid. All of us will be the moderator of Dr. Fawaz Hilal. I also expand my appreciation and greeting for all ISAC member and celebrate with them the dual membership between ISAC, Egyptian Society of Anesthesiology and Acute Care, and the European Society of Intensive Care. And we are going to have many collaboration and partnership with many of the international societies and organizations. I celebrate this with all my colleagues, either the regular membership or the founder or the golden member in my society. Thank you for your effort and your support. Thank you for you all.
Thank you.
Thank you.
Thank you. Thank you for attending. Thank you very much. See you.
Thank you for Eyad. Thank you for your effort.
Thank you.
It was
Thank you.
great and fascinating lecture.